three items of e-health, being disease management and personalized health care. I don't know if you've heard before about disease management and personalized medicine, but it really seems to be the next e-health must-have, as it is believed to be part of the solution to the problems of 21st century healthcare. 21st century healthcare is confronted with a gap between the increasing number of chronic diseases and increasing demand of long-term care on the one hand, and on the other hand, the need to cut back on costs and the decrease in active population. But why is it that disease management and personalized medicine seem to be so up to date, so promising exactly right now? As I already insinuated, it is really because of the introduction of ICT technologies that caused or that opened up a whole new range of personalization opportunities. And many ICT tools have been introduced over the last few years in healthcare. For example, electronic health records, but also interactive and web-based motivation and education tools, as well as very thorough and advanced data mining techniques. And these tools allow the patient to more and more self-manage his health status, but they also allow the practitioner to have a better overview over the health care of their patients. And furthermore, they allow healthcare insurers to compare healthcare outcomes, to do thorough risk detection and differentiate amongst individual patients. In other words, these tools cause a kind of a shift. The healthcare practitioner continues, of course, to manage the health status of the patient, but the patient gets also more involved in proactively preventing acute medical episodes. And even though this patient becomes more actively involved in the management of his healthcare insurers, on their turn, will try to steer the patient along predefined healthcare paths in order to cut back on these costs. And so that really is what disease management and personalized medicine are all about. But both concepts do have quite a long history, and for that reason I will shortly illustrate it to you. Because they do have such a long history, also many definitions have been around. Let's start with disease management. Disease management was first introduced in the United States, I believe, around the early 90s, and it was exactly done in order to reduce costs. It was thought that disease management could close the gap which had risen between the delivery of healthcare and the financing of healthcare, because predefined healthcare paths were created. However, halfway through the 1990s, one realized that maybe cost is not everything which is to healthcare, and so these healthcare paths should not only focus on cutting back on costs, but should also focus on better health outcomes. And for that reason, many studies argued for the development of practice guidelines. Now, these practice guidelines, these first practice guidelines, got a lot of criticism because they were considered by the physicians to be cookbook medicine, to be too simple. And over time, they did evolve into more complex paths or tracks which were designed specifically for certain conditions. One of the conditions which is tackled very often is diabetes, because it's so crucial in our times. What I then call a third generation of disease management programs really focus on personalization. They want to integrate care and they want to empower the patient. And a disease management program then really consists of a multidisciplinary approach, which does not only care for curative care, but also for preventive care. They want to identify person at risks and intervene by proposing specific tailored programs not only to the disease which the patient may be confronted with, but also to his whole health situation. Now, this evolution, this shift in focus on better economic outcomes to better health outcomes is something which we noticed both in Europe and the US, but as it is typical, in Europe it gets stressed just that little bit more. And for that reason, I included here a citation from the European Charter of Patient Rights. And in right number 12, they say that, as you can read, each individual has the right to diagnostic or therapeutic programs tailored as much as possible to his personal needs. But they also say that it has to be made sure that the criteria of economic sustainability does not prevail over the right to health care. And then we come to the concept of personalized medicine. Now, as you will notice immediately, both concepts are quite closely related. But personalized medicine relies even more on personal information from the patient, from the patient's lifestyle, from the patient's family history, but also from the patient's whole environment. And by combining all these elements of information, they want to create an, as you can read, integrated, coordinated, evidence-based, individual approach from health to disease. And so typically for personalized medicine is that, again, they take a proactive approach to medicine, focusing on prevention, risk detection, and only on treatment when necessary. And that's, of course, very different from what we are used to in classical healthcare, which is very reactive. I get sick and I go to the doctor. It is believed that personalized medicine, because of this proactive approach, can reduce costs enormously, especially when genetics get involved. Because genetics really can be considered as kind of the ultimate component of personalized medicine. And I can hear you thinking that genetics, do we really know that much about the relationship between genes and treatments? Well, yes and no. We do know quite a lot, and knowledge has improved over the last years enormously. But the expectations are also still very, very high, especially since the race for the $1,000 genome. I don't know if you know the race for the $1,000 genome, but it's an academic prize for the first institute which can sequence 1,000 genomes for $1,000. And it is expected that when everybody gets his full genome sequenced, a genome is like a complete picture of my DNA and by all my risks. It is expected that when everybody gets this full genome sequenced for a very low sum of money, at least in terms of healthcare, only $1,000, and probably when it evolves even less, it is expected that the knowledge will on the associations of DNA variation and disease susceptibility will allow for much more far-reaching personalization of healthcare through prevention, but also through, for example, pharmacogenomics. And as you can see, companies like 23andMe, which is here on the slide, already picked up on this very promising technology. And it's really simple. You can just send them your sample of saliva, and what you get back is a list of, I believe it's now 28 conditions, and your chances of getting that condition compared to the average population. Now you can imagine that when you introduce two quite new concepts to European healthcare, when you would introduce them in our healthcare, you kind of create a new healthcare model. And this, of course, causes issues, possibly many issues, social issues, ethical issues, and of course also legal issues. And one of the main legal issues is data protection and data security, as disease management and personalized medicine both stand or fall with the processing of personal data, personal sensitive health data. Both concepts can only achieve their goals when they get the correct information to the right actor through the proper media. And so the right to privacy risks to get compromised when these sensitive health data are not carefully managed in accordance with the legal framework which is already in place, like there are the Charter for Human Rights or the Data Protection Directive. And when we look a bit closer to data protection, we can really see that it's all about four main principles. It's about legality, it's about finality, it's about transparency, and it's about legitimacy. And the question will now be how we can assure that these principles continue to be respected even when our healthcare model would change. And I will go through all four of them quite quickly. Starting with the legality and the legitimacy principle. And the legitimacy principle is actually the easiest of both of them. I explain it quite simple now, but basically the legitimacy principle says that you have to act in accordance to the law. That's easy and not easy, of course. Following the legality principle, one must have a valid legal basis in order to process sensitive data. This valid legal basis can consist of a particular law saying that yes, you can process these health data for that purpose, but up until now it doesn't exist for disease management or personalized medicine such a law saying that yes, you can. Up until now, chances are quite likely that you have to rely on informed consent. And as some of you might know, I talked about informed consent last year, so for all the requirements, I kindly refer you to those proceedings. But what is crucial in this year's proceedings, or this year's paper, is that the informed consent has to be given for a specific purpose. And that doesn't really fit with the theory of disease management. In the theory of disease management, it is a duty of the medical field to make risk analysis also when there is no specific health question or when there is no specific reason to do testing of an individual. And then I come to the third principle, because actually this requirement of having a specific purpose is not only required when you ask for an informed consent, it's also the basis of the third principle, which is the finality principle. And consequently, this principle gets risks to get compromised as well. And let's say, even if there is a specific health question before you undergo testing, the thorough data mining techniques which we have now, and especially the genome sequencing, will cause that much more information can be exposed than what it was actually looked for. And in such a scenario, it's quite difficult to grasp all the consequences of testing and risk detection. So we really have to ask ourselves if informed consent can still serve its purpose in such an environment. Apart thereof, there is another problem with the finality principle, which is that the boundaries between treatment and research are actually fading. And they're fading for two reasons. Firstly, because large databases are needed, but large databases are needed to link the risk profiles with the healthcare parts, but the same databases are also needed to find new links, to establish new connections between certain health parts and certain diseases. And even though the reuse of health data for research purposes is not necessarily forbidden. One of the often imposed safeguards is that you will have to anonymize or pseudonymize the data that you use. And exactly this anonymization of individuals' profiles gets stressed, gets compromised, security experts will tell you, because there is so much information available, definitely when there is genetic information available, that anonymization is technically not really possible anymore. Then last but not least, we come to the transparency principle. The transparency principle will require you, it's a bit different from the other principles, but it will require you to be quite open about what you do with the data. And not only that, it's also a by user researchers often indicated crucial element for acceptance by the public. The demand of individuals for more information and more control about their data has been rising for many years. And this is not always the same as the goals of disease management companies. Healthcare insurers, for example, may not be too keen on giving patients this control. And instead thereof, they may want to evaluate the patient's consistency with the personal disease management program that was kind of prescribed to him. They may even want to account him for it, and they will definitely want to evaluate the effectiveness and economic sustainability of that program, which then actually brings us back to the finality principle and this original purpose to the data processing. So as you can see, there are quite a few issues, and therefore I cannot but conclude that data protection protects individuals against third parties who could acquire a substantial power over us through data mining. But personalized disease management programs, as much as they may be a goldmine to health insurers, will therefore have to respect the patient through the protection of his rights, but also through his empowerment. And then I can only thank you for your attention.